today, Dr. Mary Abraham. Hearty welcome to you, madam, who is a neuroanesthesiologist and a pain and palliative care physician, who will be taking us through our session today. She is a visiting consultant in various hospitals in New Delhi and has been awarded the Lifetime Achievement Award by Delhi Neurological Association for her contribution to neurosciences in 2017. And her main interests are neuroanesthesia, pain and palliative care. Not only she's been eminent in her clinical aspect, she has authored a couple of books now. The first one, Conquering Pain, which was released in 2019. And recently, last month, she has released a book on managing chronic pain. So, without much delay, I hand over to you, madam, to take us through the session.
Thank you, Radha. And thank you, Sangeet, for the coordination that you did. Once again, it's a pleasure to be here to talk about a topic which is difficult. And the title itself is Management of Difficult Pain. Okay, so cancer pain itself is difficult to manage, and difficult cancer pain is even more difficult to manage. So let me try to do some justice to this topic. So I would like to share my screen. Is it visible now?
Yes, we can see your screen.
I'll just go to my slideshow.
Yes.
So my topic is...
it's clear, madam. Okay. It's clear. Go ahead.
Okay. So this is an approach to a patient with difficult pain, primarily dealing with cancer pain. Now we are all, after the first talk, which was the WHO analgesic ladder, I'm sure all of you all are conversant with this WHO analgesic ladder, that three-step ladder that's most familiar one, in which we start off with step 1, step 2, and step 3. And step 3 is the strong opioids with or without an adjuvant. Okay? And like we know that with this, we can manage to treat 71 to 76 patients. They have very good response with using this ladder. And the patients who are the remaining patients, around 20 to 30% of patients, they may not respond even to the strong opioids. And that is called difficult or refractory pain, also termed intractable pain, persistent pain, or opioid non-responsive pain. So by definition, this it's defined as pain related to cancer or its treatment of at least 3 months duration that has not responded to standard treatment with opioids and co-analgesics. That is a definition of refractory or intractable pain. So there are some risk factors why some patients are not responding to the regular regime of the three-step ladder. One is young age, neuropathic pain, incident pain, that is pain on movement, then psychological distress, previous opioid use, tolerance to opioids, history of addiction, and impaired cognition. These are some of the risk factors why patients go in for intractable cancer. So before I start my presentation, I'll just take you through a case scenario. It's a patient I had encountered about 2 or 3 years ago, actually. This is a 62-year-old man with carcinoma rectum. He had peritoneal and liver metastasis. He was on chemotherapy since 1 year. Initially, he responded, but then he had a recurrence. Then he developed acute intestinal obstruction with pain in the abdomen due to progression of the primary lesion, most probably. He was taken to the ER because of the intestinal obstruction and admitted for conservative management. A Ryle's tube was inserted. The surgeons did not want to do any surgical procedure. So a Ryle's tube was inserted and a colostomy was done. And then he was discharged with the advice of continuing with palliative care. Initially, he was taking the WHO step 1 and 2 drugs through the nasogastric tube because he had a nasogastric tube in situ, along with the adjuvants. And then when the pain got worse, he was started on the step 3 drugs orally through the Riles tube. But one day he pulled out the Riles tube. He was against its insertion right from the beginning, and he reiterated that he did not want it reinserted. Now, he was a very weak and frail man, and it was not difficult to put in a Riles tube against his wishes. But the family discussion took place, and they said that they decided to respect the patient wishes, and we decided not to reinsert the Riles tube. But also the question was, since he was so weak and emaciated, how do we feed him? So, but they still said that patient autonomy must be respected, and they did not want me to put the Riles tube again. So we had left no option. He had a chemo port, and we started on IV fluids. Now the pain grew worse, and then he was started on transdermal fentanyl patch, 25 mics per hour, with oral transmucosal fentanyl citrate, that is the OTFC, or the fentanyl lollipop. Okay, that was 200 microgram SOS. But he still did not get relief, and he was in agonizing pain. The family was extremely distressed. So what do we do next? Now, when we come to a patient with difficult pain, there are some steps that we need to go through. First is we have to review the patient. Then we have to manage it by a combination of pharmacological and non-pharmacological options. So these are some of the pharmacological and non-pharmacological, but I will take you through this in the course of my presentation. But before anything, the first and most important step in such patients is reassurance. You won't believe the world of good a reassurance does. Just to highlight this, I want to talk about a young girl, 23-year-old girl, who I saw just 2 weeks ago. This girl had an extensive sarcoma. It was an epithelioid sarcoma of the perineal region. And it had spread to the thighs. And she was in excruciating pain. She had come down from the Nainital area to Delhi to take treatment. So they went to one of the super specialty hospitals in Delhi, and they met the gynecologist, who said that we need to first take the opinion of the medical oncologist. Now, this particular medical oncologist, he just said that there is nothing we can do. The rest of her life, she'll be miserable. And even if I give chemotherapy, it will not improve, and it will only get worse, and she'll even have urinary problems. He painted such a gloomy picture that it was, of course, not in front of the girl, but the relatives were totally devastated. And then they talked to me, so I referred them to another doctor. Now, this gentleman, he was an elderly person. He just told that don't worry, we will take care of it. See the difference between two oncologists. This gentleman, of course, that was a much younger person. He was a much older person, maybe in his even 70s, but of course, a very renowned person. And he just said, in spite of the same patient has gone, but he just said that don't worry, we will try and treat it, and we will try our best to make you better. The girl's cousin, who was actually taking all the charge of this girl, she said we were 4 of us in the room. Of course, a girl wasn't there. They just cried in front of this doctor. Can you imagine the difference reassurance makes? Because it is a difficult case. It seems a stage 4, but this gentleman just said that don't worry, we will try and treat it. So that is the important role reassurance has to play in the management of difficult cancer. Then we go to the ABCs of reviewing. The first is the treatment that has been written or the prescription that has been written, is it being adhered to in the first place? The second is, I'll talk about it in my next slide. The second is B, believe the patient. If the patient says the pain is 10 out of 10, please believe it. Because according to Margio McAfee, who said very long ago, pain is whatever the experiencing patient says is existing whenever he or she does. In simple terms, pain is what the patient says hurts. So if it is 10 on 10, treat it like a 10 on 10 pain and don't try to uh, decrease the pain or believe the relatives. Listen to the patient. That is the best benchmark for assessing pain. And then we need to do a comprehensive pain assessment. Of course, you must have gone through this earlier, but you have to go through the characteristics of pain, the functional history, the prior drug history, and even the non-drug history, and examine the patient once again, and then again review the patient. So that is what is called a comprehensive pain assessment. Do it all over again. And then, of course, we need to correct the correctable factors. It could be an effusion that has started that needs to be tapped, or an ascites, or there could be an underlying superadded infection. It could be insomnia that's aggravating the pain, or anxiety. We all know the gate control theory of pain, how anxiety and insomnia and uh, even just stress can open the gate and make the pain worse. And of course, a nutritional status. So many things that need to be corrected should be corrected. Now, coming to adherence to treatment. When we review the analgesic that the patient is taking, we should first see if they're following the WHO pain ladder. Unfortunately, I've seen many prescriptions for pain for similar patients, like I discussed earlier, where the patient is having pain because the prescription is not all right. Okay, so the morphine is not given according to the WHO ladder, which I think I don't have to say because it has just been dealt with. So we are not following the WHO ladder in principle, and that is the thing. And you won't believe that particular patient, when I just gave it the same amount of morphine, I gave it in the proper format, the same girl had relief of pain. So we have to know that we have to stick to that thing. That is by the clock, by the ladder, and by mouth. We have to stick to that. So that we, and then we also have to see whether are they giving it according to the way you have written. So you use teach back techniques. So you ask the caregiver or whoever is giving the medicine, please tell me what all are you giving and show me the chart. Okay, if you make a chart and follow that, then you can know it's objective evidence that the your prescription is being followed in the proper way. So we also have to see the adjuvants. Do we have to add any more adjuvants? So these are some of the things that you look in the prescription. Now, there are some reasons for opioid ineffectiveness. These are some of the reasons, like tolerance to opioids, addiction, physical dependence, psychological dependence, which is also addiction, patient education and awareness, and opioid availability and dispensing, whether that's being dispensed properly. So these are some of the reasons why it is not working. Okay, the drugs that you're giving, even the strong opioids, are not. So some of the common reasons for difficult to treat pain are accumulation of the toxic metabolites of opioid. I'll talk about it a little later. Then the progression of the disease. For the case that I discussed, it's possible that the disease had progressed and that is why the pain got worse. Then is there a new pain type? We all know that cancer pain can be nociceptive, can be neuropathic, it can be mixed. In fact, the incidence of neuropathic pain is 40% of cancer pain. So, or is there a bowel obstruction, as in this patient? Or is there spasticity? Like, for example, when you have CA pancreas, the spasticity in the abdomen can be translate to severe backache. So, is there spasticity? Or is there intolerable side effects like neurotoxicity because of the opioids that you're giving? Or is the route of administration that you're giving no longer successful? Or which means that either the oral absorption is poor, or the transdermal skin absorption is low, or is there a pump, needle, or catheter malfunction, particularly when you're giving IV, subcutaneous, or spinal infusions? So we have to see whether the route of administration is all right or not. And of course, we need to address the psychological, social, and the spiritual factors. That's also a very, very common reason for why pain is difficult to treat. So when you look at the management of difficult pain, I told you there are pharmacological and non-pharmacological options. The pharmacological options are, one is opioid manipulation. That means either you need to do a root conversion or you need to do a opioid rotation or a switch. Or do we need to add adjuvant drugs depending upon whether there's a new pain type or new symptoms that are occurring? It could be a simple symptom like insomnia or anxiety also. So we need to address that. So we have to give appropriate adjuvant drugs as well. Now, when we look at root conversion, what does that mean? It means we're giving the same opioid, but you're using a different route of administration, which means you're giving oral morphine, but now you have to switch to IV morphine. Or you're giving transdermal fentanyl, and now you need to switch to intravenous fentanyl. That is what is called a route conversion. Now, high serum concentrations can be achieved by both intravenous and subcutaneous route. And we can give both morphine and fentanyl in both these routes, both IV and subcutaneous. But we should remember the conversion factor. In case of morphine, it is 3:2:1. That means 30 milligram morphine if you're giving orally, then subcutaneously it is 20 and intravenously it's 10. So that is the conversion factor for morphine. Now, when you want to give the IV opioids for difficult pain, you can give it either as a continuous infusion or you can use an intermittent bolus as well for the incident of breakthrough pain. That is these are some of the devices that are available. One is a disposable elastomeric pump in which you fill the opioid drug into this balloon, and then you have a remote. So this basal infusion will continue, and whenever the patient is feeling a breakthrough pain, he has to press a remote which will give him an extra dose. And similarly for the continuous ambulatory, 1 minute, I just connect. So this is a continuous ambulatory drug delivery pump in which the drug is filled into a cartridge inside and there is a remote also. So this is the same thing. It will give continuous as well as a bolus dose. This is what is called patient controlled analgesia or PCA pump. Okay, it's given for both continuous and incident pain, and this allows the patient to self-administer the parenteral opioids. Of course, it will not exceed the toxic limits because there is a lockout period which you have to fix. So before that, the drug, even if the patient presses a remote, he will not get a dose. Now, there is no evidence of the superiority of parenteral versus oral opioids to control intractable cancer pain. But still, the European Association of Palliative Care recommends the use of parenteral opioid infusions in cases where oral or transdermal opioids fail to provide effective analgesia. The next pharmacological manipulation that we can do is an opioid rotation. Now, opioid rotation means you're giving a different opioid but the same route. For example, you're giving oral morphine, you can switch over to oral method. The indications for opioid rotation are either intolerable side effects due to one particular opioid or development of tolerance, that is poor analgesia despite titrating the drug. How does it work? This is because there is incomplete cross tolerance between the opioids. So when you give another opioid, there are some receptors which is still able to work and the patient will get pain relief, analgesia. Okay, so there is that is what is called incomplete cross tolerance. So, so then there is greater than anticipated potency with another drug because the other drug, the previous drug is not working. You give another drug because of incomplete cross tolerance. The second drug could work. Now, opioid neurotoxicity. What are the symptoms of opioid neurotoxicity for which you need to do a opioid switch? The symptoms are when the patient is oversedated or when there are neurological problems like delirium, myoclonus, hallucinations, hyperalgesia, or seizures. They are all signs of neurotoxicity. And we need to tell this in advance to the patient and the caregiver that if any of this is there, then you please inform us. We will need to either uh, decrease the dose or we need to switch. And the cause of neurotoxicity is the active metabolite morphine 3-glucuronate and normepiridine. So, when you're doing an opioid rotation, what are the drugs that are available with us? We have only two other strong opioids that is available in India, maybe three. One is methadone, fentanyl, and buprenorphine. Now, methadone is inexpensive and it can be given orally, but all these drugs, particularly methadone and fentanyl, are under the same legal control as morphine. So, how is methadone useful in difficult pain? It is very potent. It is effective for neuropathic pain as well because it can bind to the it is antagonist of NMDA receptor and also the serotonin norepinephrine reuptake inhibitor. That is why it is effective for neuropathic pain. It has no known active metabolites unlike morphine. It has a long half-life of 8 to 12 hours. It is slowly eliminated and so there is less risk of breakthrough pain. It does not accumulate in renal impairment, so it can be given in patients with renal dysfunction. There is less tendency for tolerance and no cross tolerance, and it is not very expensive. But it has disadvantages, and that should be kept in mind. There is a high potential for accumulation and delayed toxicity. There is a risk of life-threatening ventricular arrhythmia, the torsades de pontus, particularly if the QTC in the ECG is prolonged. Titration is difficult and there is a risk of overdose, and it has to be given only by experienced palliative care specialists. So, what are the indications of methadone for difficult pain? First is it's one of the drugs for opioid rotation. It is cost is low. It can be given when there's true morphine allergy, in neuropathic pain, and in renal dysfunction, like I mentioned earlier. And the contraindications I've said, when there's a QTC prolongation, you avoid it. When there's no reliable caregiver, when there's a history of sudden unexplained death in the family, which could be because of a cardiac cause, or because when there's a drug-drug interaction, like for example, azithromycin, fluconazole, and amitriptyline, you have to be cautious when you use. When you want to convert morphine to methadone, you have to calculate the oral morphine equivalent or OME. For example, if a patient is getting less than 60 milligram of morphine per day, then the equivalent methadone dose is 2 to 7.5 milligram per day. If the patient is getting between 60 to 199 morphine and is less than 65 years of age, the conversion is 10:1. That means if you're giving 10 milligram morphine, then it's given 1 milligram of methadone. And if the patient is getting more than 200 mg morphine or more than 65 years of age, the conversion factor is 20:1. That means 20 milligram morphine, 1 milligram methadone. Now, methadone is available as 5 milligram tablets and syrup of 5 milligram per ml. Now, as per expert consensus white paper, the equi-analgesic doses suggested for methadone are very conservative, what I mentioned just now, and we need not account for incomplete cross tolerance. Normally, when you account for incomplete cross tolerance, you have to reduce the amount of drug after it has been converted. But in this, we don't need to do it because these doses are very conservative. Okay. Now, when you using, for example, you want to switch over from morphine to transdermal fentanyl. So then the conversion is, if the patient is getting 60 milligram morphine, then it is equivalent to a 25 microgram fentanyl patch. But we need to account for cross tolerance. So in a patient with well-controlled pain, once you convert it, then you reduce it by 50%. But for poorly controlled pain, you can reduce it by 25% only. Like I said, the exception is methadone. You need to prescribe a rescue dose as well. Now, coming to buprenorphine, this is a third drug that can be substituted. So, this is an option for opioid rotation. It's better pain relief, good tolerability. It can also control neuropathic pain and breakthrough pain better. The various patches are available by using the transdermal route. You have 2.5 mics per hour, 5 mics per hour, 10 mics per hour, and 20 mics per hour. Each patch lasts for 7 days. Now, sublingual buprenorphine tablets are available of 200 micrograms. The effect lasts for 6 hours, especially useful for breakthrough. Now, when you want to convert morphine to buprenorphine, if the patient is getting less than 30 milligram of morphine, then you can use a 5 microgram patch. If it is between 30 to 80, then you can use a 10 microgram patch. You can supplement with immediate release morphine or non-opioid analgesic for breakthrough pain. But more than 80 milligram oral morphine, then it may not be very effective because even a 20 mic patch may not suffice. Now, I've been talking about breakthrough pain. So what is breakthrough pain in cancer? Breakthrough pain is an intermittent episode of extreme pain which breaks through the opioid regimen that the patient is on. This could be spontaneous breakthrough pain or pain that is only induced by movement of the affected limb or bearing of weight on the tumor bearing bone, etc. The incidence of breakthrough pain is 40 to 80%. To treat breakthrough pain, you need to use a fast-acting, short-duration opioid. Okay. So, what are the drugs that we use for breakthrough pain? So, immediate release morphine is frequently given. How much do you give? What they recommend is either 10% of the total morphine dose every hour. That means if a patient is getting 30 milligram per day, then you give 3%, 3 milligram. Or you can give 50% of the 4-hourly dose. So if a patient is getting 5 milligram 4-hourly, you can give 2.5 milligram. And this can be given every hour. If you're using fentanyl patch, then and a breakthrough pain occurs, then you can give 10 milligram of oral morphine. I mentioned earlier, no, that is the equianalysis. If you're using oral transmucosal fentanyl, the other drug that can be used for breakthrough pain is the fentanyl lollipop, which comes in 200 mics, 400 mics. But you should not use more than 4 per day. It should be sucked over 15 minutes and not chewed. And the effect starts in 30 minutes and lasts for 2 to 3 hours. Sublingual buprenorphine morphine, 200 mics, is also available to treat breakthrough pain. Now, once we've done the first step, then we have to see whether the pain is nociceptive or neuropathic, or is there a need for an adjuvant drug. Now, this little diagram will show you this is a pain pathway, and here we can see that this is the peripheral nerve ending which senses pain. So tissue damage is the one that is causing the nociceptive pain, and it occurs at the level of the tissue. Anything beyond this, the first order neuron, the second order neuron, and the third, all that is neuropathic component. The neuropathic pain occurs right from here, peripheral nerve, to the central nervous system. Okay. So it is basically defined as a disease or lesion in the peripheral or central nervous system. But very often, cancer pain can be both mixed. That means both nociceptive and neuropathic. Now, when neuropathic pain is concerned, and it's also very difficult to treat, when standard analgesic options have failed, ketamine is a reasonable third-line option. So this acts, how does it act? There's an NMDA receptor in the dorsal horn of the spinal cord as well as in the thalamus, and it blocks this. So it is basically an NMDA antagonist. It is useful when patients are unresponsive to antidepressants and anticonvulsants. Now, ketamine can be given by a large variety of routes, starting from oral, transdermal, intramuscular, subcutaneous, IV, then sublingual, intrathecal, rectal. And of course, you can even give it intra-articular. Sorry, this should be intra. So you can give it, but the most common ways of giving oral the ketamine is either intramuscularly or IV, or of course, yeah, these are the two. Even oral ketamine is can be done. So ketamine is it's normally an anesthetic, but it's an analgesic in sub-anesthetic doses. So when you're giving oral ketamine, the dose is around 10 to 25 milligram TDS. If you're giving as an infusion, you can give 50 to 100 milligram per day. The maximum dose should not exceed 200 mg. But in certain intractable pain conditions, you can use what is called a burst ketamine or a pulse course for a maximum of 5 days using a syringe pump. The patient has to be admitted. Of course, whenever you're giving ketamine infusion, the patient has to be admitted in the daycare or something like that. So you start off with 100 milligram per 24 hours for 3 days. If that is not effective, then you step it up to 300 milligram per 24 hours for 3 days. And if that is not effective, you go up to 500 milligram per 24 hours for 3 days. And then you have to stop. So that is what is called a burst ketamine dose, which is used in intractable pain. Now, ketamine has side effects, particularly the neurological side effects like dysphoria, hallucinations, nausea, vomiting, and dizziness. These psychotomimetic side effects can be prevented by giving haloperidol or benzodiazepine like clonazepam or midazolam. Now, another drug that is useful for difficult neuropathic pain is local anesthetics. They act by decreasing the neuronal excitability at the level of the sodium channels. And so it is good for neuropathic pain, but there could be serious toxicity. So it is only reserved as a second line treatment for severe intractable crescendo kind of neuropathic pain. How do we give it? It can be given both IV and topical, but for intractable pain, you give it as an intravenous local anesthetic infusion. So you calculate the dose as 5 milligram per kg, and that amount of drug should be put in 500 ml of normal saline and given over 1 hour, along with cardiac monitoring. It can also be given as lignocaine patches, but they are not very effective in intractable pain. The other topical drugs to treat neuropathic pain are topical capsaicin and topical gabapentin. So if you look at the neuropathic pain ladder, the first line of treatment is the anticonvulsants and antidepressants, and the duloxetine, which is an SNRI, and a lidocaine patch. The second line is opioids and tramadol. And the third line is baclofen, mexiletine, capsaicin, ketamine, and cannabinoids. So let's discuss cannabinoids in difficult cancer pain. Now, these drugs have been used for various ailments since ancient times. But in medicine, the use has been restricted because of legal and social concerns, because of drug misuse and abuse. But a few symptoms in cancer can be resistant to current palliative care treatment options. In spite of absence of robust clinical data, it is still people give it for because there can be some benefit because of cannabinoids. So it is not routinely yet included in palliative care treatment. So how do they act? These endocannabinoids act on two receptors. One is the CB1 and then CB2 receptors in the CNS. Now, CB1 is found in the brain, spinal cord, peripheral nerves, etc. They are poorly expressed in brainstem, and that is a reason for low incidence of respiratory depression with cannabinoids as compared to other opioids. But it is a CB1 that is accounting for the well-known psychotomimetic effects of cannabinoids, like the euphoria and the hallucinations. Now, CB2 is mainly found in the immune system. It has no psychotomimetic effects, and these agonists are being investigated for therapeutic uses, like it has its analgesic potential, anti-inflammatory potential, and even an anti-neoplastic effect. So it's now being investigated for that use. That is a CB2 agonist. So the two phytocannabinoids that have been extensively studied are the THC, which is a tetrahydrocannabinol, and the CBD, which is a cannabidiol. Now, nabiximol or Sativix is an oromucosal spray containing 1:1 combination of THC and CBD. It has also got anti-inflammatory properties, and they are well tolerated with improved analgesia in opioid unresponsive cancer patients. So, what are the preparations that are available? The one is which has the THC dominant ones, and they are the synthetic preparations. They are dronabinol and nabilone. Okay, so they have a tendency for the psychotomimetic effects. Then you have a combination of THC and CBD, which I mentioned earlier, that is nabiximol, that is 1:1 ratio of THC with CBD. It's available as a oromucosal spray. Then we have the CBD dominant drugs like cannabidiol, which is a 99% pure oil, can be given orally. But just remember, all these drugs come under Schedule 1 drug with a high potential for abuse. So for cancer pain, the cannabinoids have a comparatively, it's comparable to weak opioid. And weak opioids are either codeine, tramadol, or tetramadol. So after 15 to 20 milligrams of THC, the peak effect occurs in 3 hours and lasts up to 6 hours. It can be given every 6 hours. So it can be used as a third or fourth line treatment for neuropathic pain when conventional treatments fail. It's also used in chemotherapy-induced nausea vomiting. The drugs that are used are dronabinol and nabilone. I'll just skip these because this is beyond the scope of this topic. Now, the side effects of cannabinoids. One is the neuropsychiatric effects. So it can aggravate pre-existing anxiety, schizophrenia, and depression. It can cause impaired cognition, like excessive sedation and impaired motor skills. There is an infection risk because it reduces the host response, and it has got cardiovascular side effects like hypertension, hypotension, tachycardia. So you should avoid it in patients with heart disease. So what is the role of cannabinoids in palliative care? It can be given as a third or the fourth line drug for neuropathic pain. It can be used to treat chemotherapy-induced nausea vomiting, for cancer anorexia, HIV-related cachexia, multiple sclerosis-associated spasticity. It improves mood with antipsychotic effects in chronic illnesses. It also has anti-cancer activity, and it's good for the sleep disorders and seizures. So in this study, which was published in 22, it was entitled Medicinal Cannabis Shown to Reduce Pain and Need for Opiates Among Cancer Patients. So it reduced the consumption of opioid-based analgesics with this minimal side effects. This was a paper published in Frontiers in Pain. Now, is the use of cannabinoids legal in India? What is the current status? Now, in foreign countries, it is approved for the treatment of neuropathic pain and multiple sclerosis and refractory pain and cancer. But in India, the trade and consumption of cannabis is banned under the NDPS Act. Calls for legalizing its use for medicinal purposes have grown stronger over the years, and petition was filed in the Delhi High Court. And in January 22, that is 2 years ago, the central government told the Delhi High Court that the use of cannabis is not completely banned in the country. Its medical and scientific use is allowed under the law. So that is the current status of the use of cannabinoids in India. So another difficult to treat condition is when you use steroids. It's a multi-purpose adjuvant. It can be used for a variety of conditions like neuropathic pain, bone pain, headache because of secondaries in the brain, for arthralgia, because of bowel obstruction, and for spinal metastasis. So dexamethasone is a first-line drug. It has a long duration of action, so it can be given once a day. And it could provide short-term relief of pain and beneficial for those with less life expectancy. Now, GABA receptor agonists, they are also used in some difficult pain situations. We have two GABA receptor agonists. One is GABA A, which includes the benzodiazepines. But out of that, only clonazepam is used for neuropathic pain. And we have the GABA B agonist, which is baclofen. So baclofen or lioresal is effective for refractory neuropathic pain, particularly when there is spasticity involved or musculoskeletal spasms. So you can start with 5 mg BD or TDS and you can go up to 20 mg TDS. Now, bone pain is yet another important cause of refractory pain, and it is because of skeletal related events, because of the metastasis in the bones. So this can be very agonizing and it can affect the quality of life. So what are the various options? We can use steroids and non-steroidal anti-inflammatory drugs when there's multifocal bone pain, or calcitonin, but the latest review shows no significant improvement in the quality of life with calcitonin. But the most commonly used drugs for bone pain are the bisphosphonates and denosumab, and they act by inhibiting the osteoclast-mediated bone resorption and reduces the skeletal-related events. And of course, there is the option of palliative radiation. Now, malignant bowel obstruction is quite common in this particular patient that I discussed. He had most probably that. So it is sometimes inoperable and it's an important cause of refractory cancer pain. And one drug which is especially useful is octreotide, which is a synthetic hormone. It's a somatostatin analog. How does it act? It decreases pancreatic blood flow, decreases the portal blood flow, the gastrointestinal motility, all the secretions, and increases water and electrolyte absorption. So it can be given both as a subcutaneous infusion, and it has been told that it's a drug of choice for malignant bowel obstruction, and it can be combined with steroids and hyoscine as well. So now we discuss the pharmacological options. Let's go on to the non-pharmacological options of management of difficult cancer. So in this step 4 are those drugs, those interventions that can be used for those 20 to 30% of patients which are not responding to step 3. So what are they? They include nerve blocks, epidurals, PCA pump, neurologic block, spinal cord stimulators, intrathecal infusions, etc. These interventions can be done for refractory cancer. So these are some of the interventions I mentioned, all these. So these can be considered in patients with severe side effects from drugs and whose life expectancy is more than 3 months. Okay? Otherwise, if you put an expensive pump and it is patient is, life expectancy is less than 3 months, it's not, economically viable. Then you can also have neurolytic procedures like the neuroablation procedures, celiac plexus, superior hypogastric plexus, ganglion impar, stellate ganglion, lumbar sympathetic plexus, intercostal nerve, and trigeminal neurons. There are also central neurodestructive procedures. Now, these are very, very invasive and they can be the risk benefit, there's more risk than the benefit. So these are some of the rhizotomy, gangliotomy, chordotomy, etc. But these are very rarely done, associated with very high risk, and only when the life expectancy is less than 3 months, and the risk-benefit ratio should be assessed before you plan such procedures. The other non-pharmacological therapy which you can use for patients with refractory pain is dry needling, acupuncture, biofeedback, psychological therapy, physical modality, spiritual therapy, and alternate therapy. So dry needling is quite useful in difficult cancer pain, especially to treat muscle spasm and the myofascial pain. So you can either needle the myofascial trigger points or you can needle the muscles that are in spasm. How do they act? They act by causing reflex relaxation of the muscles and improves the hypoxic local energy crisis, which has occurred because of the sustained contraction of the muscle. And it also releases the trapped inflammatory mediators. So we are using this quite extensively. So physical therapy also, there are many physical therapy modalities that you can use in palliative care, which is one of the important non-pharmacological strategies. Then, of course, there is psychosocial and spiritual issues. There could be fear, anxiety, depression, anger, guilt, financial issues, fear of the future, concern about the loved ones, loss of role or role reversal, and even questioning God. So these are some of the psychosocial and spiritual issues seen in refractory cancer pain, which need to be addressed. How do we do it? Counseling, communication, reassurance, medicines also, using support groups and providing support for the family, financial support. So let's get back to our case scenario. We need to find out the cause of intractable pain. Now, one of the medical reasons why this patient was having refractory pain was, could there have been a progression of the disease? Because the colostomy site definitely looked unhealthy. Or was there a failed route of absorption? Was the oral absorption less, and was the transdermal fentanyl absorption not effective? Or were there other psychosocial concerns? What was done for this patient? We readmitted him to the hospital. A colostomy was found to be non-functional. In fact, there was a lot of necrosis around it. That was obviously the cause for the severe pain as well as the progression of disease. So opioid route conversion was done. He was getting a fentanyl patch. Now he was started on a fentanyl infusion with supportive care. Gradually, the pain subsided, and then end-of-life care was instituted, which was explained to his relatives, but the patient expired free of pain 2 weeks later. But were we too drug-centered or too intervention-centered in our approach? Were there other non-pharmacological interventions? So we need to see whether other non-pharmacological interventions would have been helpful. Now, there were a lot of psychosocial concerns in this patient. He was a highly educated retired doctor. He had no financial concerns because it was fully covered with insurance. He had a supportive family, wife and caregiver, and wife was a main caregiver. And she had taken the role of the head of the family, managing all the financial aspects and the medical aspects, everything she was managing. But he had other psychosocial concerns. He was depressed because, being an educated person, he knew that there was no cure and he would not live long. So he had a sense of hopelessness, helplessness, and powerlessness. Then he was also experiencing loneliness and isolation because the family had withdrawn from friends and relatives for 2 years. It was especially during the COVID pandemic, all the more reason that they isolated themselves. Then he had a low self-esteem. He was totally dependent, even for his personal self-care activities, on his wife. Then he was having a lot of guilt feeling. His family had given up all their activities. His wife had given up a job so that she could be his full-time caregiver. So there was a sense of guilt as well. And then there was a role reversal. He was the head of the family, but now his wife had taken over all his responsibilities. So you can see there were so many psychosocial concerns in this patient. So this is once again reiterating that when you have all these 3 steps failing, then we need to go in for interventional therapies. But all the time, you must address the psychosocial concerns of the patient. So if everything fails and if there's a terminal condition, then you must consider palliative sedation. Otherwise, accept failure but never desert the patient. Be fellow travelers with them in their difficult journey. Be frank about failure, but convey it with sensitivity, and continue with psychosocial spiritual support till the end. And any worsening or any intercurrent problems must be treated. That's it. Thank you so much.
Thank you very much for taking us through. And this is something which is essential. Like, see, anyone who deals with patients can get to a stage where it might be difficult to manage. It is not that 21%, 71% can be, and that still that fraction will be there. And for that also, we need to have options. And that is what you have taken us through. Like always, we say option A, option B, option C, option D. When you have everything in hand, and then you can see what option suits for that particular patient. And one more thing I was also thinking, Madam, someone had a doubt of using ketamine uh, outside hospital, and we were telling that it should not be done, and you have reiterated that also. I think that doubt also would have been clarified by the for the person who had that. And so big thank you. And anybody has any doubts, please unmute and ask, or I will check the chat box also in the meanwhile. So you can, anyone who has a doubt can unmute and ask straight away or type in the chat. Anything is okay. We have a case discussion, case presentation also, madam. We have that for today. If there are no queries straight away, we can go to the case presentation and then have the queries also dealt with. Sangeet, maybe we can go on to the case presentation.
Sure, ma'am, sure. So today's case presentation is by Dr. Blessy Jones. I welcome Dr. Blessy Jones to present. Over to you, ma'am.
Okay. Yeah. Good evening, all. Thank you, Mary ma'am, for the wonderful session. Thank you, Radha ma'am. I am Dr. Blessy Jones, working as consultant oncologist, St. Thomas Hospital, Changanasheri, Kerala. Today, I am presenting a case which presented to us like on January last week. Shivadas J, like 59-year-old male, is diagnosed CA prostate stage 4. Next. His presenting complaints are he presented with lumbar backache with radiation to both lower limbs. He came to our OPD in non-ambulant condition. He also had history of poor urinary stream, urgency, and nocturia of 1 month duration. So he was initially admitted in orthopedics department with lumbar backache and severe excruciating radicular pain. Right leg was greater than left leg of 1 month duration, and there initially the diagnosis was lumbar IVDP with sciatica. So later there was he was discharged, and we had a consultation because of sclerotic mets, and then he again presented in neurosurgery department after 1 week with complaints of worsening of the pain, and there was a possibility of neurological to rule out the possibility of neurological deterioration. So cauda equina and spinal cord compression was ruled out, and the pain was managed. Then he was transferred to the urology department, and already CA prostate diagnosis was done by that time, and so bilateral orchidectomy was done, and he was started on anti-androgens, that is abiraterone acetate. During the hospital's stay, patient developed agitation and mild disorientation. He was diagnosed to have delirium, and medication was started. Then while on anti-androgen, that is abiraterone, he again developed pain, that is after 2 months, over the right chest wall and left leg, which was also managed with palliative radiation and morphine. So it is a case of castration-resistant prostate cancer and a really aggressive disease. So we stopped anti-androgen and was started on weekly chemotherapy. We started him with weekly docetaxel. So he has already completed 4 weeks of weekly docetaxel. But during the last visit, he presented with pressure sores over the right gluteal region, right trochanter, and left scapular region. And so coming to the pain diagnosis, pain over the lumbar region was 1 month duration, and it was aggravated by even with minimal movement. Rest and analgesia are the relieving factors. The pain was continuous aching type of pain with a sharp shooting radiation to the both the legs. So it was worst pain with which he couldn't sleep, and he described this as worst pain, and NRS score was 10. Temporal factors are temporal factors is constant pain with fluctuation in the intensity in the radiation of the both legs. So that was treated, and later after 1 month he developed pain over the right chest wall and left leg, which was of 5 days duration, and it was even provocating factor was minimal movement, and it was alleviated with rest and analgesia. The quality of the pain was continuous aching pain with no radiation, and the severity is NRS 7 with no temporal factors. Coming to the examination, he was conscious oriented with ECOG performance status of 3. His Glasgow Coma scale was E4, V5, M6, pulse rate 56 per minute, BP 120/80, respiratory rate 22, SpO2 97%. So his main system examination, that is CNS system, had power, right? Both upper limb was normal in power 5/5, right lower limb power was 3/5, and for the left lower limb it was 4/5. So there was a mild neurological deficit there. Then respiratory system was normal, air entry bilaterally equal with normal vesicular breath sounds. Cardiovascular system was within normal limits, and GI was also normal. Next. So coming to the local examination, he developed pressure sores or the gluteal, right trochanteric and left scapular region. Gluteal region, there were 2 pressure sores, 2 into 3 centimeter and 2 into 1 centimeter, which was stage 2 with no slough. Over the right, the lesion over the right trochanteric region was of size 4 into 5 centimeters, stage 1, no slough of foul smell. In lesion, coming to the lesion in left scapular region, it was of size 7 into 5 centimeters, stage 2. A slough was present, but it was not foul smelling. Next. Coming to the treatment and significant investigation, all the routine blood investigation, CBC, RFT, LFT, serum electrolytes was normal. Even the serum PSA was being at aggressive stage 4 disease was normal. Serum CA was 2.7, and serum and CA 99-9 was 40. His other investigation like serum electrophoresis, peripheral spheres were all normal. Coming to the radiological investigation, in my MRS, lumbar spine showed wedge compression of L5 vertebrae with lytic and sclerotic lesion at multiple vertebral levels, and expansor lytic lesion of the left iliac bone. So coming other metastatic workup was done. CT chest and abdomen showed primary prostate neoplasm with seminal vesicle infiltration, bone mets, liver mets, adrenal mets, lung mets, and nodal mets. Coming to the histopathology, TrueCup biopsy revealed adenocarcinoma prostate, Gleason score 5+5, grade 5. So initially, during the first visit itself, we started him with anti-androgens, and then we focused on the palliation of the pain. Palliative RT was given to C7, D1, L5, and both iliac bones, 20 grain 5 fractions. Later on, urology consultation was done, and bilateral orchidectomy was done. Then after orchidectomy, he was started on anti-androgen abiraterone for for initial treatment, like just to bring down the testosterone level. Then he developed pain over the right chest wall and left leg. So there was lesion in the left femur and rib lesion also. So we gave him palliative radiation to the left femur and right rib lesion, 20 grain 5 fraction. So being aggressive castration resistant disease, we stopped him with we stopped anti-androgen and started him with weekly docetaxel. Coming to the a psychosocial aspect. He's a 59-year-old man living with his wife and 2 sons. He was working as a canteen manager in Food Corporation of India. He was the only source of income for his family, with his wife being a housewife and 2 dependent sons in college. So initially when he presented to us, he was in non-ambulant condition. So his main concern was whether he would walk back to his work, because he is soon going to be retired, and the retirement function was to be held on April 30th. So his family was very supportive, gave him a tremendous psychological support, and also they were all exploring, being even if it is advanced metastatic terminal disease, they were keen on exploring all the treatment options. And they were also giving him mental and psychological support. At present, he's not having any financial issues, as all the insurance coverage are met. He has insurance coverage from his work. So next. So the medications are, he's now on weekly docetaxel. He has completed 5 cycles. Yesterday it was his 6th cycle, and tab icalutamide BD. So initially we gave him 4th hourly morphine only 4 times. Then the pain was not controlled, and now he's on 10 milligram morphine 4th hourly and 20 milligram at night. And tramadol 50 mg BD was given initially. Now it was SOS. Then tab gabapentin HS, tab bisacodyl 5 mg HS, syrup lactulose 15 ml HS and SOS, tab metoclopramide 10 mg 1 SOS. So he was advised airbud and change in position, and wound dressing twice daily, and also cleaning and dressing with debrid ice because of the slough over the left scapular region. And also he was asked to apply local white petroleum jelly over the other lesions, which is over the gluteal and right trochanteric region. So initial our concern was regarding he was presenting with L5 compression fracture, and we were suspecting neurological deterioration to cauda equina and subsequently paraplegia, and that might need decompression and spine fixation, but it was not needed. Then the initial concern of the pain and other things like mental and psychological issues, delirium, were all controlled, but later or this recently our main concern is bed sore, which really give him a worry. Then now, and also he has retired on the April 30th. So there will be a problem with insurance coverage, because almost all the funds are depleted. So they were they worried about continuing the oncological treatment. And also regarding post survival, even if we have multiple options, the survival of this patient is very poor, being a stage 4 terminal cancer. Coming to summary, he's a 59-year-old male presented with lumbar backache with radiation to both lower limbs of 1 month duration and other urinary symptoms of 1 month duration. He was diagnosed with stage 4 prostate cancer with extensive bone mets, liver mets, lung mets, adrenal mets, and he underwent bilateral orchidectomy, palliative radiation to both sides, and he's currently on palliative chemo and has presented with pressure sores or the left scapular, right gluteal and trochanteric region of 1 month duration. Oh, sorry, 1 week duration. Coming to the discussion points, so it is already being was dealt by Mary Madam regarding the reassurance, and there's options of psychological support for patient and caregiver are really minimal. In this case, the patient is non-ambulant, and he being and he's very obese, and also his wife was the sole support, like both physical and emotional support. So we saw a deterioration. His positive attitude was coming, and his quality of life was improving, but at the same time, quality of the life, the positive outlook, and also the self care of his wife was deteriorating. So that was also an issue. So a need for psychological support for the caregiver, then the need for effective communicating, because being a terminal aggressive cancer, we need to effectively communicate regarding the importance of continuing oncological treatment for improving the quality of life, and also for alleviation of pain, because primary will lead to alleviation of all the symptoms despite being a terminal, in terminal aggressive disease with poor disease. So we need to acknowledge that palliative care is ethical responsibility of health system, and it is our ethical duty to alleviate pain and suffering, whether physical, psychosocial, or spiritual, irrespective of whether the disease condition can be cured or not cured. That's what the case presentation madam said. What the reassurance is has went a long way. So usually, as an oncologist, we used to overlook the need for palliative care. But in this case, we could integrate both the palliative care from day one of the visit, and hence the quality of life of the patient has very much improved, and his power has regained, and his pain scale, now the patient does not have any pain. So that's importance of integrating palliative care with oncological treatment. Thank you.
Thank you, Dr. Blessy. You've taken us through a case which was more relevant to, he has gone through the different aspects of pain, and you took us through as madam had instructed. One of the doubt you clarified at the last minute. I was about to ask you about the pain after the treatment, and you said now his pain relief was good. And madam, you can go ahead and say comment on, and then there's one question in the chat box which I will read after that.
Oh, I must first congratulate Blessy for a very good presentation, very detailed presentation, and I think very effectively managed. Very good. And yeah, and like I said, that integrating palliative care to the oncology right from the beginning, initially we'll have a small role, but as the oncological options are failing, then the palliative role will increase more and more. But being familiar with the palliative care doctor right from the beginning makes a lot of difference, because there will be a very natural progress and natural way in which by which the palliative care will take a more important role towards the terminal stages of the disease. So that's very nice, and I think the case was very well presented. And yes, if there's any, I was just thinking that see, patient had this L5 wedge fracture, and that was obviously leading to the compression of the exiting nerves. So that was one of the causes for the back pain and for the radiculopathy. Yes. So in such patients, I would have also done a bit of dry needling for this patient. Because whenever there's a wedge fracture and radiculopathy, it means there's a lot of muscle spasm. Okay, because the paraspinal and the deep spinal, both superficial and deep spinal muscles are in spasm, and that is aggravating the mechanical compression. So in addition to the mechanical compression, there is also a compression because of the muscle spasm, which could be reversed. So adding a muscle relaxant, even muscle relaxant you can add, but dry needling would have been very good to relieve his back pain and radiculopathy. And you could also step up the dose of gabapentin. You're giving only 300 mg. That could be increased. You could have added a antidepressant as well, like amitriptyline to that also. And particularly these patients with wedge fractures, even osteoporotic wedge fracture, I have seen them having a lot of muscle spasm and they respond to dry needle.
Yes.
Very safe option. OPD procedure, they can go home immediately after that if their patient is OPD patient. So that was something I would have added. That's all.
Yes.
Otherwise, I think the treatment management was very good. If there are any doubts, please ask. Anybody in the audience?
I'm like, exactly. I was also about to tell, like, madam, the dose of anti-neuropathic would have been increased because
Would have been
that
increased.
will give, which
Because whenever
madam
there's
has
a
mentioned.
nerve compression, these anticonvulsants and antidepressants, particularly the anticonvulsant, decreasing the the sensitivity of
Excitability.
the nerves. You see, so
Yeah.
you could increase this more, like 300 mg twice a day or thrice a
BD.
day. Also, you can give. Okay,
Yeah.
and that will also an antidepressant also would be useful in this patient.
Yes.
The antidepressant has a double way of acting. It acts for neuropathic pain. It's also a sedative.
Psychology.
Okay. Yeah.
Madam, the question in the chat box was by Dr. Sharmaga Priya. So her query is, if it is all what we have discussed is for chronic or extensive cancer pain, can the same regimen be used for diabetic neuropathy and those type of things also?
Yeah, but for diabetic neuropathy, you don't have to go through the. See, it's a diabetic neuropathy is a mainly a neuropathic kind of pain. There's no nociceptive component in that. Not much. I mean, I would not say there is. So you don't have to go through the WHO step ladder. You can straight away go in for your anticonvulsants like gabapentin or SNRI. Like pregabalin and duloxetine are very good drugs for diabetic neuropathic pain. Okay, so but I don't think paracetamol and morphine and NSAIDs will work in that kind of. But you can
They can,
use these anticonvulsants and antidepressants effectively in diabetic neuropathy.
they can use the neuropathic pain ladder in that those situations.
Yes, tramadol is good because tramadol also acts on neuropathic pain.
SSN.
So if among the weak opioids like tramadol will be effective for that kind of.
Dr.
Along with
Shanmuga
that,
Priya, if you want to still ask something on top of it, you can please unmute and ask.
No, that's clear. I just wanted to know whether we can use the ladder for the neuropathic pain. That's what ma'am
like I
has
said,
given
paracetamol and non-steroidal will not be very
not
effective.
work. Okay.
Because whenever there is diabetic thing is tingling, numbness, and burning pain, so they are very neuropathic pains. So they respond to the neuropathic pain ladder.
Yes, that's what. Okay. Thank you. Thank you.
Non-pharmacological will also help there, which also can be tried because already they are on so many medications. So always, like what to say, you should have a patient methodical approach. It's just giving matter of time, as we have been telling from the beginning. You may have to give a couple of weeks for these type of medicines to start working itself. That is where reassurance and explanation to the patient, no? Like as we have all seen in these few sessions, the main understanding the pathophysiology of this neuroplasticity and all what we say, madam explained it today also, the nociceptive and neuropathic element to be understood as this being a sort of last session for pain. We still have opioid availability and few things, more sessions on this, but I just wanted to add on that. See, you have to understand why and how this is happening. It is just not the whole nervous system, and the whole nervous system can behave in different ways. That is what, it's not like a fixed. That's why I said on the first or second day of this campaign, it's not hardwired. It said, if you take any books and it will say it's not a hardwired system. It can take other routes also, because that is why the presentation is so different. Just radiotherapy, chemotherapy can all cause neuropathic pain. So because of so much of involvement of the nerves in different levels, different connections. So if these are explained to the patient, so they see many times they think, oh, I am experiencing all this and telling people don't believe me. No, no. So if you give reassurance and explain to them this is how it is, that is why they are, both for the patient and family, it will be very reassuring.
Comprehensive pain assessment is very, very important. And for that, you need to know the basics of what is nociceptive pain, what is neuropathic pain, is it a mixed pain, and then treat it accordingly. And if there is a muscle spasm, add the muscle relaxant, maybe baclofen, or even a regular muscle relaxant like thiocalcicoside or tizanidine or something. But in this patient, that will also have helped. And please look at the non-pharmacological options also. And it's ultimately a very multi-pronged approach. A multimodal therapy should be done, not relying too much on just drugs, but look at other options also.
I've been telling the same thing, madam. Multidisciplinary approach to identify multimodal management. So these two, like mantra, you can take.
Yes, here
The,
the oncologist, the pain specialist, the palliative care doctor, the nurses, the psychosocial doctors, workers, all of them have a role to play in this particular patient.
when everyone works together, no, it is like additive effect.
Well-oiled machinery. And the patient, ultimately, it's possible that the patient may not live long, but even then, you won't believe the caregivers will thank you for making that patient's life comfortable. See, that is the
That is,
test. The patient has gone, but the relatives are happy that the patient went peacefully and with dignity, and they will always thank you. Even you were treating, the patient died, so normally you should get the flack, but it's not so. In palliative care, if you've given a peaceful end and pain-free end to the patient, they will always be grateful to you. I've seen it in my practice. So
that is quality of life. No, that
yeah.
is quality of life till the last breath.
Yeah.
That is
Unfortunately, I was
exactly.
discussing about that one patient, right? So when they went to the first medical oncologist, I mean, the words he said was so bad that I felt bad when I heard it. This is a relative telling me that oncologist said, you have come in such a condition, whatever life you're living, whether you get treatment or not, you're going to be miserable. Can you imagine? You live in misery and you'll die in misery. I thought that was too harsh. Even if the patient is going to die in few months, by telling this, you're demoralizing everybody in the family, including the relatives.
Yes.
So when the other doctor gave hope, these people started crying in front of the doctor because they've got some hope that at least she will not be miserable. She's a young girl, just 22 years. So, I mean, the attitude also matters, of everybody.
Yes, as Madam has mentioned, this is very important. And another thing, what I try to say to patients is not every patient will go through, say, for example, even someone is in stage 5, need not go through all what we read and think. Many patients have a better way. Just morphine gives them so much pain relief. Like I have seen few patients who were like stage 4 or 5, and they would have started attempting corrective curative management, not obtaining much relief. So in that stage also, just with oral morphine, I've seen so many patients could get back to being on their feet and doing things for themselves, which gives so much relief, and they pass away so peacefully. Not everyone goes through. So in fact, the other way around, we have to say, we can be with them, assure them, and not a must that everyone goes through. For that, you have to see patients and walk with them to know what it is. So even recently, there was a lady who was diagnosed with a fracture in multiple levels in this one. Just in 2-3 days, she was started, and then she had a very peaceful passing away. So not a must that everyone goes through difficulty. Okay, so those are the things. And just let me read a couple of things there in the chat box. That's what they mentioned about the attitude. Yes, it's so important. Like as we've been all telling through these sessions, you see, if it were you on the other side, will you be happy to listen to all that? And what is that we will wanting to expect, and those type of things will help us. And as you go through these sessions and also see patients together is what will be helpful to take us through. A physiotherapy in relieving pain. Is there any
Yes, I did
role
mention
for physio?
that. Can help to a certain extent. Maybe some cold packs or hot packs or whatever they do, TENS, all that can make a difference. TENS and IFT all can. Like I said, it is a multimodal therapy. You cannot clap with one hand. You need all these hands to work together.
And many centers have already started doing these type of things. They all have, and for example, in Pallium we have not only what to say, you will we have daily meetings in which all the teams sit together and do, and also in management, from management point of view, like physiotherapies, psychology, all work together. Like for example, in the rounds, if we see, many times the physiotherapy team will also come with us, and the psychologist will follow us as soon as we have seen. So like that, it's a combined approach is what will be helpful, and the benefit you will see with the patient, like in a week's time or something, you will see the difference, the same, like pain scoring, their attitude, their glow in their face, and them being able to do few things for themselves. So or when the approach is done as a team, the benefit also is better, and ultimately everything is in patient's best interest. That's what we are trying to do. So ultimately, if patient's going to get benefited in any way, be it pharmacological or non-pharmacological, what is our ultimate goal? Patient needs to feel better, and if patient can smile, that is what is the ultimate goal. Anybody else wants to ask anything? You can unmute and ask also.
And most of people have been silent today.
Mostly, madam, like one or two of the queries were in your topic itself. As I was telling, they were asking about ketamine, and when your slide came up, I thought, okay, they would have got the answer from it, like that. We have had sessions on, as you are aware, no, we have had sessions on morphine, methadone, also.
Yeah, I know that.
So. In that case, I will hand it over to Sangeet.
Thank you, ma'am. Thank you, Dr. Mary, ma'am, for the wonderful presentation. Thank you, Radha, ma'am, for facilitating, and thank you, Dr. Blessy Jones, for the extremely wonderful case presentation. Thank you, everyone. Thank you for joining. Let's see you in the next session. Bye.
Thank you very much,
Thank
Dr.
you.
Mary.
Thank you
you
so
very
much.